Thank you everyone for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch title is Meaningful Use Stage 2 Action Plan. Today's Learning Lunch is brought to you by Medical Mastermind, a leading provider of EHR and PM software solutions. Mastermind EMR was designed by doctors, so it is a beautiful workflow that actually meets the needs of clinicians. Visit www.medicalmastermind.com to learn more. We're joined today by Joy Rios of Format Approved. Joy is an expert in both meaningful use and EHR proficiency. With years of real-world experience in meaningful use attestation and EHR implementation and optimization. Joy has a unique talent for taking forbidden materials such as meaningful use and distilling it down to the information you need to succeed. Now, before we begin, we're going to ask our guests to participate in a quick informal poll. You should see the question appearing here in just a moment. All right, so go ahead and make your selections, and then we'll share the results here with everyone. And it'll give us a sense of where people are in meaningful use, which we thought would be a nice way to kick things off. So please take a moment to answer that question. And we're going to close it here in just a minute, and then we'll look at the group's answers. All right, while you continue to vote, remember that you can ask questions of our presenter at any time during today's session by entering them into the chat area. Oops, go back there. In the second half of our presentation, we'll address as many questions as time allows, but if we do run out of time, we have a lot of people on this session, so we might well, then we'll follow up with written answers to your questions if we don't get to some of them. All right, let's look at the answers to our poll here. All right, can you see those answers? Joy, can you see those?
I can, yep.
Okay, great. So it's interesting. Some people have attested for stage 1, but a lot of people, and some have already received their reimbursement, but there's still plenty of people who haven't done it yet. So we've got people in different places, but regardless, everyone needs to get ready for stage 2. So Joy, with that information, let's go ahead and begin, if you don't mind. First of all, thank you for joining us. It's always a pleasure to have you.
Yeah, thanks for having me. It's always a pleasure to be here.
All right, well, let's start grappling with stage 2 if we could. What are the milestone dates for 2014 that people should keep in mind?
So there's a lot to keep track of, and the first and easiest date to remember is the first of the year. That's going to be when the 2014 reporting year begins for stage 2, and of course also for a continuation of stage 1, no matter what year you're in. February 28th is going to be the last day to register and attest to receive payment for the 2013 year. So people should be preparing now to making sure that they're collecting their data and gathering it all, or at least getting a system in place so that they know, and that they're ready as soon as the year changes over. You've got 2 months to register and attest. After that, you will no longer be able to qualify for the incentive payment. One thing to pay attention to for next year, particularly in stage 2, is that all stage 2 participants must, they have a 90-day reporting period that are fixed to the calendar year quarters. So anyone in stage 2 is limited to their reporting period of January to March, March to June, etc. Stage 1 and also Medicaid participants can report any 90-day period. So that's another thing to keep in mind. Another big date is October 1st. That's when we are going to see the ICD-10 code set implementation. That should be something that is going to be affecting billing and also just billing and coding in general. So I'm sure that that's something everyone has heard about and is getting prepared for, but that's definitely something that's looming.
ICD-10 apocalypse, as we like to call it.
Hey. Exactly. And then for those that are still in stage 1, October 3rd is the last day that they can start their 90-day reporting period. So that's not a stage 2, that's more a stage 1 date. And then of course the last reporting date is the last day of the year, so December 31st.
All right, so for people who are moving from stage 1 to stage 2, what are the biggest challenges, or the biggest changes rather, that they're going to face?
Sure. Well, stage 2 retains a lot of the basic structure as stage 1 of meaningful use. So providers still need to report on 20 objectives, but the way that how those objectives are divided has changed a little bit. So it's still split into core and menu objectives. Many of the stage 1 menu objectives have been pushed over to core objectives. And what you'll see is that there's now 17 core objectives that are mandatory, that eligible professionals have to report on, and then they have the option to choose 3 of 6 menu objectives. And you'll notice that a lot of the threshold changes, so even the stage 1 core objectives that have stayed, that are still there, and the ones that have transitioned over from menu, they have different thresholds. So for example, the smoking, keeping track of the patient's smoking, where before it was 50% in stage 1, it's now 80% in stage 2. And that's pretty much consistent across the board. So definitely keep an eye out for those types of things.
And it really illustrates how, as you move through the stages, there's sort of this, this process of building one stage on top of the other.
Absolutely.
Makes sense. So what are the new stage 2 objectives then?
So there are 6 in total. The first new core has to do with secure messaging. We're going to go into a lot of detail, but that's an absolute core requirement. So all EPs are going to be required to have a 5% tally or threshold, of 5% of their patients that they have sent and received secure messaging. There's also 5 new menu objectives. So one is recording of electronic progress notes. Those need to be seen for 30% of unique patients. There's also an imaging. Imaging is where the results and explanation of the imaging need to be accessible through the EHR. So for 10% of scans and tests ordered, you need to be able to see the order as well as the result within the EHR. So we're going to go into more detail, because that has a little bit to do with, hopefully interfacing and making sure that you're connected so that you don't necessarily have to manually enter all that data. An easy win is the family history. So there's a lot of, patient engagement and family engagement that is being encouraged, but specifically one of the new menu objectives is to record family history as structured data. So they're looking for 20% of unique patients with 1 or more first-degree relatives of their health history. And then there's also the cancer and specialized registry. So where in stage 1 that you were really just required to test and make sure that you could submit to these public health registries, now they're looking for ongoing submission, and people should be thinking about this 60 days before the start of their reporting period. So if you're choosing the reporting period, April through June of next year, then you should be setting up and getting ready to submit to these different public health registries if you're not already. So that one is really important. So folks can talk to their EHR vendor and start looking for the local registries where they can submit those to. So we'll go into detail on that in a little bit as well.
So there's a lot of interest and maybe concern about this one. What do providers need to know about the data transmission requirements?
Well, this really relates to a lot of the health interoperability and health information exchanges. So one of the strong HIE implications is for the summary of care records. And so I've talked about this a lot recently with folks, and it's really how to be successful when you're providing these summaries of care. So they're requiring you to to share the summaries of care with 50% or more of transitions. And then you need to be able to transition these summaries of care not just to the folks with the same EHR, but also folks that have completely different EHRs. So this particular measure has, or this objective has a couple of different ways of measuring it. One is that more than 10%, you can meet it in multiple ways. One is through sending it and using your certified EHR technology, and another is contracting with the network that NWHIN, become an exchange participant. So these will give you information on how to find these people. There's another name for it called the eHealth exchange participants, and it's everyone from, state-specific groups to places like Kaiser Permanente or, even the VA or whatever, but those are places that they are kind of middlemen, that if you want to be sending information, they can go through them. And then there's also an alternative way where you can send these summaries of care successfully through a test of what they call a CMS designated test EHR. And there's only 3 of those that exist that I've been able to find. The test EHR pilot program participants are Athena Health, McKesson, and Meditech. So those are if you know anybody in your circle or referral network that is using those, if you want to send any summaries of cares to providers that are using those particular EHRs, they will help you meet that measure because they're part of that test EHR pilot program sponsored through CMS. So yeah, there's a lot of, and if you're not signed up for an HIE, we have instructions on how to do so. There is a program which we've discussed before, Brian. It's the UCSD or UC Davis program that they're doing a study on which EHRs are ready and already set up to connect with health information exchanges. So you can go check to see if your EHR is on that list by going to their website, which we'll provide later, and then from there finding your community, regional, or state HIE and making sure that you're connected with them. So those are the pieces that need to be in place in order to be successful in a lot of these objectives that require the sharing of data. So EHRs need to be ready specifically, and then all of the connections need to be in place. So it's a lot to manage.
Yeah, and probably new territory for a lot of folks.
Yeah.
Now, what about lab and radiology interfaces? What do providers need to keep in mind for them?
Well, this one is interesting because this is the first time that one objective requires 3 different or multiple percentages within one objective. So you've got, in order to meet the medication, this is the CPOE, the computer physician order entry. So this can be, there's been talk about who can actually place those orders. It's any credentialed medical assistant or healthcare professional. But that means 60% of medication orders need to be placed from within the EHR, 30% of lab, and 30% of radiology orders need to be ordered electronically. And the requirement is for all 3 to be met in order to meet this one objective. So that can be a lot. That's going to require interfacing most likely, or at least it makes a lot of sense to set up an interface so that you don't have to manually enter, save yourself that trouble. And the exclusions for this is if you have within the reporting period less than 100 orders, so if you have less than 100 prescriptions, less than 100 lab orders or radiology orders, then you can be excluded from the measure. So that is one thing to think about. But another thing is building upon the stage 1 measure option. Stage 2 requires folks to incorporate more than 55% of their lab orders into the certified EHR technology as structured data. So this relates to clinical lab tests. And specifically, they're looking at lab tests that come in the form of a number. So it's, if the result is in a positive or negative format, then they want that information as structured data so that it can then be, manipulated and looked at. So it would really make sense to have, and think that it may actually require, in order to meet that 55% benchmark, it may need multiple lab interfaces in order to meet that. So one thing to keep in mind in order to make life easier on yourself is to learn how to template those orders. So within your EHR, you should be able to customize order sets that you can potentially order a medication, a lab, and an image all at the same time, just at the click of a button. So that is something that you can work with either your EHR vendor or somebody who's your expert team lead that can help customize that for you, so that way it's just a much easier way of, killing multiple birds with one stone, essentially.
All right, well, before we go on, we're going to do another quick polling question. You should be able to see that now. Just get another sense of where our audience is on getting all of this done. So go ahead and vote now. Now, Joy, the recent news, and I hate to spring this question on you, but the recent news about the delay in the requirement for stage 2, how is that going to impact things? The idea here is that people don't necessarily have to begin stage 2 in 2014? Or have you?
My understanding is
Yeah,
My
please go ahead.
understanding is that it's an extension of the deadline. So we're still starting at January. Stage 2 still begins January 1, 2014. But instead of going until, having stage 3 start in 2016, I believe, they've pushed it out a year.
Well, I don't
So
think
that
that
should
surprises too many people. They've always been kind of hinting around that that stage 3 was really not going to start in 2016.
Yeah, exactly. So I think I personally think it's good news for everyone. It gives people more time. It gives the vendors more time to keep their product up to date and more time for users to learn whatever changes have come down the pike. So I don't know. I don't personally see anything bad about it, but we'll see.
Well, you can see the results of our poll. So it seems like a lot of our audience is doing some of these things, at least to some degree, and then others haven't really done many of them so far. And I really think that a lot of people out there are in that boat. So people are in lots of different places with this stuff. All right,
Well,
let's continue.
it's good to know that people are doing it to some degree. You should definitely have a start on all of this stuff. It's not all brand new, but it is a lot to implement at one time.
All right, so let's talk about the patient engagement requirements. I think a lot of people are kind of concerned about this one.
Yeah, this one has gotten a lot of attention because not only are providers now being checked on, measured about what they have done, but they're being held responsible for what their patients have done, or at least 5% of their patients. So that's where we've really come into the conversation about patient portals and giving patients access to their relevant, their health information. So one thing to be thinking about is, do you have already access to a patient portal? This is where patients are going to need to have the ability to view, download, or transmit their health information within a 4-day time frame of that information being available to the doctor. So this needs to be done for 50% of patients. And this is one of those aspects that they say that, giving patients access to their health information is critical to making healthcare more patient-centered, because it gives them the tools to electronically communicate with their clinical care team. They can, ask questions when they need to, find information, and, send it on to places where, maybe they see multiple doctors or a different specialist, and they can have that information at the ready. Another requirement, not only just the view, download, transmit, we've talked a little bit about the secure messaging. So that means your portal, if you have one, or if you don't have one, it should have bi-directional secure email with patients. So it should give you the opportunity to send an email to patients and also to receive email from those patients. And so you also want to, a portal is is one way that really facilitates the electronic access and email in a way that protects the privacy and confidentiality and security of that patient. So they're definitely HIPAA safe in that sense. And you probably know that most EHRs don't have that ability or capability at this time to send messages specifically to the patient. It's usually users within the practice or users of the EHR system. So the portal is really going to be a critical component for stage 2 participants, and getting people signed up for them, and making sure that marketing them, teaching users how to get the information that's relevant to them is going to be also very important. So
yeah, we've talked in the past about how there's some simple things practices can do, and maybe we'll talk about this a little bit later, to try to promote that messaging. And 5% is really not a very high number. So obviously people who are maybe in areas where there's fewer internet users, or their population doesn't use email as much as some others maybe, might have some concerns. But this is, to me, very important. I'm kind of a HIPAA hobbyist in some ways, you could say, and you've got to get secure messaging to make this work.
Sure, and I think that there's ways of, it's really just about getting the system in place. I think that stage 2 is looking for folks to all right, this is a component that's going to be required. We need it. We need people to start using it, but I think that they understand you can't expect a 50% or 80% threshold for that, at least not yet. So it's just a matter of, getting the system in place, similar to getting the EHRs in place for stage 1.
Yeah, they're really trying to ease people in, I think.
Yeah.
All right, so when it comes to workflows, what do folks need to look at in reconfiguring those?
Well, it's really important to start thinking about the internal operations and the processes that are currently in place that you have to support your meaningful use objectives. So start thinking and identifying, okay, what works really well? What are we doing great, and continue doing that. Identify things that are either small or real problems, or workflows that are totally broken and a source of patient complaints. This is a time that we can take the opportunity to redesign the workflows and match the core and the menu objectives that you're signing up to tackle. So everything from answering phones, how you take appointments, messaging, scheduling procedures, renewing prescriptions, making referrals, like how you give patient education to the patients and also with their families. All of that can be taken into consideration. And of course, how are you getting in your lab orders? That's specific. That's one that's really important. Essentially, there's no workflow too small or too big that can be improved for stage 2. So, and one thing to really keep in mind is try to stay committed to not automating a bad workflow process. So if something does not work well and you're in the paper environment, the last thing you want to do is to, create the same exact, you're going to get the same bad results if you transition the same workflow into a digital environment.
That's great advice. Well, we already have a lot of questions from our audience, and I want to remind everyone that you can go ahead and ask questions at any time. We're going to save those for the end of our session, but we always have a lot of questions when Joy is with us, so we welcome those. The other thing I'll mention quickly is that people have already asked about getting the slides and a recorded version of the event. We always send those out to all registered attendees, whether they attend or not. So you'll get those in our follow-up email to this session. So if you're looking for the slides, don't worry about that. Okay, so then when it comes to the EHR vendors, Joy, what should providers be asking them?
Well, think about this. Your best intentions, or a practice's best intentions for meeting the requirements of stage 2 are pretty much useless without the cooperation of the EHR vendor. So because it's 2014 and there's new specification and certification requirements by all EHR vendors, you definitely need to make sure that your EHR vendor is certified for the new stage 2 2014 certification. If they are not, then you're in trouble. So that would be like question number 1 to the EHR vendor. Are they stage 2 certified? And if not, how soon will they be? How far along are they in that track? And it should, most EHR vendors have been working on this for quite a while, so it shouldn't be a surprise question, and they should be expecting that. They should also find out, one, they should be ready or getting very close to ready for the ICD-10 implementation, and also ask them, are they in direct compliance with the interoperability specifications for data exchange? So how you connect to an EHR today is slightly different from how you might connect going forward in 2014. So the CMS is requiring vendors to be compliant with specs that they've outlined in the final rule. So if the vendor's not in direct compliance today, a practice should ask when it will be and what will be the direct impact on the process. And I would say, lastly, it's really, really important to start thinking about what kind of training would be needed. So if the EHR is going to be going through an upgrade, or if folks are transitioning to a new EHR that actually is meeting the stage 2 requirements, make sure you ask what kind of training your practice is going to need to work with the updated system. You may need to change specific workflows, find out what kind of updates they've made to the system. It could be something that's just a patch and a minor thing, or they could have overhauled the whole thing. And if so, then you need to make sure that your staff and everybody in your practice is ready to handle all the changes.
So should providers take a technology inventory? And it seems obvious what that is, but maybe tell us a little bit about what would be involved.
Sure. Well, again, we're talking about things that need to be ready. So your EHR needs to be ready for stage 2. And also because of the ICD-10 changes, your practice management system should be ready to handle that too. So both of those pieces need to be in place. And of course, the portal is super important. So if you don't have those 3 things that are all up to date, and those could be causing you trouble down the line. So I would start, in addition to just looking at the software, looking at your internet connection. For anybody who's cloud-based, the time that it takes for you to go to access all of the areas of the EHR is only as fast as your internet connection. So those types of, any type of ancillary, if you have any computers that need software or hardware upgrades, make sure to keep track of those. Look at your internet connection if you have anything cloud-based, and also anything that's interfaced is using, for the most part, internet. And then, of course, your practice management EHR and portal.
Yeah, and if you have a really creaky old network, this would be the time to maybe take a look at that as well. As you put more and more load on that, really, it might be time to take a look at that. So when it comes to quality measures, the good old CQMs, how should providers be planning for those?
This is one of my favorite topics.
I knew you would love this one.
So providers need to have a quality plan for their quality measures. So next year, all providers, as part of stage 2, need to be submitting 9 clinical quality measures as opposed to the 3. And actually, it's not just stage 2. It's any provider in any stage, because it's the 2014 CQM rule change. So no matter where you are, even if it's your first stage or your first year of testing for meaningful use, there's 9 clinical quality measures required. So
I'm really glad you said that, Joy, because I think that a lot of people don't understand that we're in a new ballgame with CQMs regardless of your stage.
Yeah, it doesn't matter. Even if it's your first year, it's 9. So CMS has a recommended adult core set, so 9 measures that pertain to adults. They have 1 for pediatrics, and then they have an additional, I think it's 64 total quality measures that you can choose from if those 9 recommended core sets don't apply to you. Now, keep in mind that when you're going to be testing your quality measures, it's not going to be most likely the same registration and attestation that you submit your core and menu measures. This will happen through a CMS web portal. So if you're familiar with the IACS, you need registration. You need to register for that type of an account and then get on the portal so that you can submit your quality measures electronically through them. If you are aligning with the PQRS quality measures, one thing that's really important to pay attention to is the reporting period. So even though for 2014, the reporting period for the Meaningful Use program, no matter what stage you're in, no matter what year, is the 90 days, for PQRS, the reporting period is a full calendar year. So if you do plan on aligning them, then you will not be able to submit your attestation and be complete with it until the beginning of 2015. You know, you'll have January and you'll have it again until February 28th, 2015 to submit that information. So that could delay your incentive payment program money, because even though you may have submitted your core and menu objectives, it's not complete without the CQMs. So that's just one thing to pay attention to. Medicare folks will be submitting it through the IACS, that CMS portal, and then Medicaid, they submit, folks that are participating in the Medicaid program, they submit their measures to their state Medicaid agency.
All right, well, here's the million-dollar question. How can providers get ahead of the game with so many changes coming?
Yeah, there's a lot to keep track of, a lot of moving parts, a lot of moving pieces. So I recommend a team huddle for one. Make sure you get everybody in your practice on board and have open, clear communication, identifying your biggest challenges, and kind of dividing and conquering who's responsible for what, and you know, anticipate these types of. I mean, it will be challenging. It's not all going to be super easy. So make sure that you can offer your staff any kind of training that they need. These types of learning lunches and webinars that, you know, are helpful for just sharing information and getting people up to speed on things are really, really helpful. Make sure your billers are prepared for ICD-10. Offer, you know, if you can and are able, offer courses and certifications now to all members of your staff, and start thinking about, you know, which workflows you can. So if you haven't started any of these conversations with your providers, with your practice staff, and even with your EHR vendors, and even your, you know, regional extension centers and your health information exchange folks, like, it's time to really start talking and really communicating. So I'd say, you know, staying ahead of the game is making sure that, you know, it takes a village. This is a village, you know, community effort, making sure that everybody can work together and help each other kind of take on this challenge.
So when it comes to things like getting ready on the patient portal, what would you recommend for that sort of thing?
What do you mean by well, if they, one, talk to the EHR vendor may have a portal that they offer that already integrates with the EHR, and if so, that's fantastic. If it doesn't, then you're going to need to find a portal that that can integrate or interface with your EHR. So many people have, you know, the same EHR and practice management system, and then they may have a third-party patient portal. So tracking, you know, knowing which situation you're going to be in is one thing, and then also making sure that you know how to use it, your staff knows how to use it, and you can communicate with patients in a systematic way, you know, making sure that they know how to sign on and how to get access. Is that what you mean, or was there?
Yeah, I mean, the idea that you're going to have to promote the patient portal, I think, is an important one. If you really want patients to start using it and to meet those thresholds, you need to have some kind of plan for making them aware of it and proactively encouraging them, those that are interested, to actually engage and use it.
Yeah, so there's a lot of methods that people have come up with. One is, you know, posting signage in the waiting room and making an announcement about it, having something that's up on the front desk that's just like a small little reader, just a little sign that, you know, as people are checking in, they can see that as well. As folks I've found that people are more responsive to getting their patient information at checkout rather than check-in. And so maybe, include a workflow that, the front desk staff offers that information on how to log in, instructions, and what they might find about their, what relevant information will be available to them. That's one way. Just starting the conversation is one. And then if providers want to go the extra step, they could have a kiosk or a tablet or computer or something within the waiting room that if they want to get patients to log in right then and there, they could practically guarantee that they're going to meet that 5% threshold.
And when it comes to this bullet about adding new reporting requirements now, the idea here is that you're beginning to collect that data, so when it comes to the reporting period, then you've already had some practice. Is that the notion here?
Yeah, that's right. Yeah, as soon as all of this is going to be habit forming. So the sooner you can start forming the habit of meeting all of these requirements, then the less challenging I think it will be going forward. It's just a matter of managing change and getting used to it in maybe bite-sized pieces.
So here we have some URLs for folks. Tell us a little bit about these resources.
Sure. So part of the requirement to get involved with the eHealth, Healthy Exchange, or the NWHIE participant, here's where you can find out who those participants are. So that's that first resource. If you're looking, and that is when you're exchanging clinical summaries, 10% need to be done through an EHR that is not the same developer or vendor that you have. So you can choose to use an exchange participant. So there's the information for that information. If you have not signed up, or you don't, if health information exchanges is somewhat of a confusing topic, you can first go to HIE Ready. There's that UC Davis program that will tell you if your EHR is ready to be connected to an HIE. And then the next one is looking at your state, community, regional HIE there. So it has contact information so that you can start that process. And I found this last one to be really useful. HIMSS published a document that shows how the HIE in particular has what implications it has on each individual measure. So it just goes stage 2, step by step. You can see, okay, what is the importance of the sharing and being connected. So this is all part of stage 2 interoperability, data sharing, and making sure that things are connected. So these 4 resources here can help get you on the path in the direction of where you need to go, and an explanation of why and how to get there.
Well, we're going to leave these up. I want to remind people you're going to get the slides, so you don't necessarily have to scribble down these URLs, but I know some people may be excited to get to them right away. We've reached our question and answer stage, but I'm just going to leave this screen up while we go through the questions so that people, if they want to, can visit these URLs. But before we get to the questions and answers, let's do a final polling question while I sort through the questions, if you'd like to participate. So based on what you've seen today, the question is, what do you think your biggest hurdle is to meeting these new objectives? And I'm going to sort through our questions here. We've already gotten a lot of questions from the audience, but please, if you haven't asked your question yet, please go ahead and put that into the chat area, and we'll get to as many as time allows. All right, I'll let that polling go for just another few seconds here. In fact, why don't I ask the first question while we're waiting for the poll to finish, Joy, if that's all right?
Sure.
So the first question is, isn't there a penalty if you don't attest for stage 1 in 2014 by October?
Yeah, this is the year that penalties begin. Good point. Yeah, so this is definitely crunch time. The penalty begins 2000. It's applied in 2015, but based on this year. So yes.
All right, so you can see here from our results that people have different concerns around this, but a lot of people are a little nervous about everything, which seems reasonable with all the changes coming. So we thank
Yeah.
everyone for participating in the poll. That's all. It's always interesting to see where people are at. Okay, and so when it comes to the penalties then, those start at, what is it, 1% or 2%?
I believe so. Let me
And they
confirm.
rise every year by 1% for those who don't attest, and up until, I think it caps out at 5% if memory serves.
You're right. I mean, that's correct. They do. It goes up to 5% and it starts, but if you don't start by 2014, then you get the penalty of 1% in 2015, 2 in 16, 3 in 17, and so forth, up to 5.
Right. And so, you know, we've talked about this before, but penalties for PQRS are coming too. So for folks who who participate in Medicare, they potentially face some pretty significant penalties down the road if they choose not to participate in the programs.
Yeah, if they don't do either. So it's a 1.5% penalty in 2015 as well if you don't report here in 2013, and then it goes up to a 2% penalty in 2016 and each year beyond that. So if you continue, if practices decide just not to do anything, that, depending on the size of the practice, they could get hit with, you know, there's value-based modifier penalty as well. So they could hit, you know, it could be up to 7% of a negative payment adjustment with all the different programs combined. So each one individually may not be such a hard hit, but certainly all of it together could have real negative implications.
Yeah, and you know, the larger penalties are a bit down the road, but certainly the time to start, well, it's actually a while ago, but if you haven't started now, is definitely the time. Let's move on to another question, though. Okay, so is it true that any attestation, regardless of the stage of the program, must be on a 2014 certified EHR? It must be such an EHR to even start the 90-day reporting period.
No matter which year no, it's only for stage 2.
Because
so
the EHRs certify by stage, right? So,
yeah.
you know, and go ahead.
Oh yeah, so if you're in stage 1, year 1 or year 2, you can stick with an EHR vendor that does not meet the 2000 or the stage 2 requirements. But as soon as you get to stage 2, as soon as you're ready, that vendor needs to, if you're on that EHR, then that vendor will need to be upgraded to the new specs that are published by CMS. So if they're not, then you're in a position that you have to switch, really, if they're not planning on doing it, because you're the one that you will be the one that gets the penalty, not the vendor.
Right, because, you know, obviously the incentives are tied to providers.
Yeah.
Now here's a question that I think we've addressed, but just to be clear, the question is, when does attestation for stage 2 begin, and is it required for 2013? Well, no, not 2013, and it begins in 2014, correct?
Say that again?
The question is, when does attestation for stage 2 begin? Well, that would actually be...
Oh, it would be, well, January to February of 2015. That's one thing that I don't think, if you have the 90-day reporting period, and let's say your reporting period is January to March, and included with your CQM, say you're not aligning to, if you're not aligning to PQRS, That is something that you may be able to start attesting once your reporting period is complete. I need to confirm that, to be honest. So I'd like to follow up just to make sure I'm 100% on that. But I've tried before where the period that you're reporting needs to be from the previous year. So there are some situations. I know that with Medicaid, it's definitely, at least in California Medicaid, you have to be attesting from the previous year. So if that's the case across the board, then you would, even if your reporting period is January to March, you wouldn't be able to submit your attestation until January of the following year, 2015. But let me confirm that, because I don't know that that's true across the board.
And just to address the audience's member's question about 2013, no one's attesting for stage 2 at this point. So, you know,
yeah,
it
it's
hasn't
brand
begun
new.
yet.
Nobody's. That's right. Yeah, no. All of these, all of the stage 2 requirements, objectives, and whatnot all go into place starting January 1. So that's the very first time, you know, the beginning of the reporting period that could possibly begin. So if you're ahead of the game and you're already meeting some of those standards, well, fantastic. But they won't be measuring you on that until next year.
All right, well, here we have a question about secure messaging. And I'd like to remind our audience that we will be sending out written answers to these. So every once in a while, if there's questions, Joy just mentioned that she'll follow up to confirm that information. Sometimes people ask questions about particular codes or, you know, technical issues. So we always give our experts the option of deferring to the written answers if they want to look something up. But anyway, on the secure messaging, the question is, does the patient have to initiate the message for it to count, or is it okay if the EP, which eligible professional, initiates and the patient responds?
I think I have not read anything specific, but it says bi-directional secure email with patients. I've noticed that CMS has a tendency to leave things open to interpretation a lot because it can, they want to apply these rules across so many different specialties and practice types. So I think that it actually would be a great idea for EPs to initiate that secure message, and then if they get a response, then that is what would be added. But I will confirm that as well. But my inclination is to say that yes, that EP can initiate it, and that would be a great workflow to put in place, you know, making sure that you are emailing a certain number of patients within that reporting period.
So here's a question, I think probably about the delay, or the extended deadline rather. So do we still have to do stage 2 in 2014 if we have done stage 1 for 2 years?
Yes, absolutely. Yeah, so they haven't changed the way that the program runs altogether. Essentially all they've done is given one more year to stage 2.
Right.
Which will be interesting for those early adopters, folks that started in 2011. You know, they may only need to report stage 3 for 1 year and then be out of, you know, incentive money that they can receive.
Oh, but you know, some of us believe that there will be a stage 4. I guess
Really?
legislation for that. Well, I'm hoping for one, but anyway, that's not a mainstream view. So here's
We'll
another question.
see.
Here's another question for you, Joy. Is everyone, regardless of what stage they're in, required to have a functioning patient portal in 2014?
It's not a requirement, so it's just when you're looking at the ways that you can accomplish the view, download, transmit, and the secure messaging, I have yet to see anything besides the portal that would be the solution. So the portals definitely have to be certified EHR technology, so you're looking for, you know, even if it is a third party, some of the information that is going to be gathered from that portal, because it is, you know, you're looking at the numbers of how many patients did secure messaging, how many patients viewed, downloaded, or transmitted their health information. The reports that come out of that, they need to be certified. So you're looking for a portal that has the same type of either Drummond or CCHIT certification, most likely as a module like a modular certification. But no, it's not a requirement. It's not a, if you find another solution, let me know, because I'd be interested in knowing what it is, because it needs to be a certified, a third-party certified technology that has the same functions. So it could be something that is incorporated into your EHR already, or again, the third party. So we'll see how folks figure that out and what solutions that they find for it.
Well, here we have a couple of related questions. The first, I'll ask the first one, and then I think the second one helps to reinforce it. Will there be penalties for docs who don't move to EHR or qualify for receiving the meaningful use incentive money is the first question. And we've talked a little bit about the reimbursement penalties, but then the second question is, has there been further talk about the penalties for those who don't attest when the incentives are done? So on the one hand, you've got the penalties. Maybe we should just briefly review what those are again.
Okay, so in 2015, you would receive a subject for a 1% negative payment adjustment or 1% penalty. 2016, you've got 2%, 17, 3%, 18, 4%, and then it stops at 19 at 5%. And that is for either not attesting at all or not attesting successfully.
And then down the road, there's talk about, what could happen in the future, that the idea is that this sort of digital technology will be so incorporated into medical practice. I mean, there was the huge controversy in Massachusetts where they talked about making use of EHR be contingent on you keeping your medical license. There's a lot of pushback against that. But there's talk about other penalties that might apply down the road.
Yeah, I don't know about all of them, but it will be interesting to see how it all unfolds. It seems like the CMS is being very aggressive in making all of these changes. I mean, we really have just seen so much happen in the last couple of years, and I imagine that it's only going to get more. There's only more on its way.
So here's an interesting question. The question is, does anyone know if it's a requirement to do off-site server backups? Now, my understanding is that that wouldn't be a meaningful use requirement, but it does, HIPAA certainly requires a disaster recovery and contingency plan. So from a HIPAA perspective, I think the answer would be yes. Do you have any insight to add to that, Joy?
I think that they're all interrelated. So if it's a requirement of HIPAA, then it would by default be a requirement of the EHR incentive program.
Well, they've certainly tried to tie them together. We're going to talk here in a minute about the risk analysis that's required for meaningful use. So that's a HIPAA requirement, really, but they basically made it core measure 15 of meaningful use, that you have to do the same, meet your HIPAA obligations in that regard.
Right, right. Now, if you're using a cloud EHR, then all of your information is not on site. That's something that would be, by default be captured and stored off-site somewhere. So that could be, one solution. And if you have a server-based or a local installation of your EHR, it probably is absolutely a good idea to have off-site locations of those backups. But I don't know if they would include that in the, as part of the real requirements to meet for meaningful use. But I wouldn't be surprised if they put that in. They've put other things in that are
maybe a little surprising.
Yeah.
Well, the answer, certainly we could say that you should do it.
Yeah, agreed.
So we have another question about EHR certification. When do vendors have to be certified for MU2, or do they even have to be? Do they have the option of not getting certified at all?
Sure. I mean, a lot of so think of how many hundreds of vendors there are, right? This is where I think we're going to start to see the elimination of some, because some smaller folks may not have the financial capacity, or they may not have the technical team to be able to keep up with all of the development. So that's definitely something to keep in mind if you have an EHR that they're absolutely not required to meet the stage 2. There's no mandate for them to do so. However, it's in their best interest if they want to keep their clients, if they want to keep all of the practices using their system, then they should certainly be incentivized to meet the stage 2 certifications and beyond. So,
but it really speaks to the need, I think, to talk to your vendor and if you haven't already, and make sure that they are either already certified or plan to be certified for stage 2 if you're participating in the program, because there's no guarantee.
They should have a plan. If they don't have a plan, then you're in trouble. So that should be, getting off this call should number one thing, call your vendor and find out what their plan is. And they shouldn't have any issue telling you what it is. They should be able to be very clear and concise and say, hey, this is how far along we've gone. These are the challenges that we're facing, and we expect to have them, met or completed in X amount of time or by a certain date. So yeah, shouldn't be something new to them at all. But it's certainly not a mandate for them to keep up.
All right, so do be sure you have that communication with your vendor. They've probably gotten the question many times already, so as Joy was saying, it certainly should not be a surprise for them. We do have other questions that we didn't get to, but as I said before, we're going to save those questions, send them on to Joy, and she will provide written responses to those. There's interesting questions about CQNs and some of the websites we talked about, so do keep an eye on your email inbox for that. I'd like to thank Medical Mastermind, the sponsor of today's Learning Lunch. Medical Mastermind is a leading provider of EHR and PM software solutions. The EMR was designed by doctors, so it has beautiful workflow that actually meets the needs of clinicians. We're big fans of Medical Mastermind here at Format Approved, so we encourage you to visit www.medicalmastermind.com to learn more about their products. And I should mention that Medical Mastermind will be Stage 2 ready this spring, going along with what we were just discussing. Thank you, Joy, for joining us for today's Learning Lunch. It was a great session, very informative for people.
Thank you for having me. I really do enjoy these.
Be sure to read Joy's regular column for Format Approved called Ask Joy at www.formatapproved.com/hitanswers/author/joyr. It's not the easiest thing to find, but if you go to Format Approved and click on Content, you should be able to find her column without too much difficulty. I'd like to thank our attendees. Remember that you'll receive an email with links to both the slides and the video recording of this session. Do you need a meaningful use risk analysis for your 2013 attestation? Now, this is something that I think a lot of people may not have thought through. Core Measure 15 requires a risk analysis that it needs to be completed during the reporting period. So even though you have time left to attest for 2013, even into the new year, very little time remains to complete the required risk analysis. As audits for meaningful use expand, providers report that failure to complete a risk analysis is the #1 reason why they fail the audit. Now, as part of a special year-end promotion, Format Approved is offering a $300 discount on that risk analysis. Use the discount code MUSPECIAL to receive that discount at www.formatapproved.com/education/HIPAA_secure/risk analysis. That also is not the easiest thing to get through, but you can see the link there on your screen. So go to our site or look for the follow-up slides, and if you need that risk analysis, there's not a lot of time left. Visit formatapproved.com to learn about our upcoming Learning Lunches. The Learning Lunch button there on the bottom of the screen will take you to our upcoming webinars where you can learn more and register. Our next Learning Lunch will air December 17th and has the title, EHR Replacement, What Do I Need to Know? Keep an eye on your email box and our homepage for other upcoming topics, and thank you again for joining us today.